Hello,
Hello.
I'm Mohit Yadav.
Yeah.
Can I know your name?
My name is Yadav.
Okay. So I'm gonna take examination of thorax and lungs.
Okay.
Okay. You have to remove your t-shirt.
Okay.
Note the shape of chest and how it moves. Normally, a resting adult breathes easily, quietly, and regularly for 14 to 20 times a minute. Inspect the patient's neck for these accessory muscles. If present, it suggests respiratory difficulty. Palpate the sternal notch to check the opposition of the trachea. It should be in the midline. Check the patient's color for circummural and nail bed cyanosis. Examining the posterior thorax beginning with the inspection. Observer chest for counter symmetry and deformities. Also inspect for the overlying skin.
Tell me if this hurts.
Palpate the chest wall to locate any areas of pain or tenderness or any lesions or bruises.
Please breathe in deeply.
To test chest expansion, place the thumbs close to the patient's spine, the level of the 10th rib, and ask the patient to inhale and exhale and see for the diverge of thumbs for 2 centimeters.
Now I'm gonna press my hands on your back. I want you to say 99, 99 over and over until I tell you to stop.
99. 99.
Feel for the vibration of tactile
99.
firmitus as the patient say 99. Using the ball
99.
of your hand, identify for the
99.
increased or decreased or absent firmitus.
99.
Continue examination by percussing the chest in the systematic manner, moving down the thorax and going from side to side as demonstrated in ladder pattern. Remember only interphalangeal joint F. Your pleximita should be in contact with the chest wall. To avoid the damping, wrist motion should be relaxed and fluid as you make strike. With the tip of the third plex, here we are trying to transmit vibration through the bones of the plex scimitar joined to the underlying chest wall. Next, ask the patient for breathe out and use percussion for identifying the lower level of diaphragm. Ask patient to take full inspiration and measure descent of diaphragm. Excursion is usually 3 to 5 centimeters. Oscillation is the most important technique for assessing airflow. If we hear an abnormal broncho-vascular sounds, assess transmitted voice sounds.
Now you say 99.
99.
Normally, the sound transmitted are muffled or indistinct. Bronchophony, louder sound reflected transmission through airless tissue. Next test for egophony. E to A changes which occur in lobar consolidation from pneumonia.
1, 2, 3.
Finally, check for whisper pectoral and ask the patient to whisper 1, 2, 3. Whispered voice usually heard faintly or indistinctly. Examine anterior thorax. Have patients lie supine. Observe the condition of skin and inspect chest for deformities. Next, palpate the chest to locate any area of tenderness or access any lesions. Then access chest expansion. Place your thumbs along each costal margin with your hand along the lateral ribcage. Next, palpate for tactile firmities. Compare both sides of chest using ball of hand. Firmities is usually absent or decreased over the precordium. Next, percuse the anterior chest and lateral chest. Percuse and progressive steps down in the midclavicular line.
Just take breath.
Ask the patient to breathe mouth open and compare the symmetry area of lung using ladder pattern. And identify for any adventitious sounds.
Say 99.
99. 99.